My name is Dr. Jonathan Keaton, and I've been working as a neonatologist for 22 years here in Memphis, Tennessee. For those who don't know, a neonatologist is a pediatrician who specializes exclusively in the care of newborn babies, particularly those who are premature, critically ill, or require intensive medical attention in the first few weeks of life. Every morning at 5:30 a.m., I walk through the doors of Le Bonheur Children's Hospital and head straight to our neonatal intensive care unit. It's a world of controlled chaos, incubators humming, monitors beeping constantly, tiny babies fighting for their lives while teams of nurses, respiratory therapists, and doctors work around the clock to give them the best possible chance at survival. In my 22 years doing this work, I've seen miracles that would make you believe in the impossible. Babies born at 24 weeks gestation, weighing less than a pound, who grow up to be healthy, thriving children. Twins who arrive so small they can fit in their father's palm, who go home months later in their parents' arms. Newborns with complex heart defects who undergo surgery in their first days of life and grow up to run marathons. I've also seen heartbreak that would tear your soul apart. Parents who hold their premature baby for the first and last time. Families who spend months in the NICU, only to lose their child to complications we couldn't prevent. The weight of responsibility that comes with caring for the most vulnerable patients in the hospital is something that every neonatologist carries with them every single day. But what I'm about to tell you isn't about the miracles or the heartbreaks of modern neonatal care. It's about a discovery I made just 2 months ago that has fundamentally changed how I view the medical history of my city, and frankly, has kept me awake at night ever since. It's a story that reveals how the very profession I've dedicated my life to was once used as a weapon against the families we're supposed to protect. It started in November of last year with what should have been a routine professional obligation. I received an email from Dr. Evelyn Carrington, the conference coordinator for the American Academy of Pediatrics annual meeting in San Francisco. She was inviting me to present a research paper at their prestigious historical medicine symposium. The topic they wanted me to cover was Evolution of Neonatal Care in the American South, Historical Perspectives and Modern Advances. I was honored to be selected. This type of presentation only comes around once in a career, and it would be attended by some of the most respected pediatricians and medical historians in the country. But I also knew it would require months of extensive research into historical data that most people would find mind-numbingly boring. Infant mortality rates, hospital practices, medical protocols, and neonatal outcomes dating back to the early 1900s. Memphis seemed like the perfect case study for this presentation. Our city has been a major medical center in the region for over a century. We have multiple teaching hospitals, a rich medical history, and comprehensive records dating back to the 1920s. I figured I could use Memphis as a representative example of how neonatal care had evolved throughout the South. I started by reaching out to colleagues at the University of Tennessee Health Science Center, the Memphis Medical Society, and the archives departments at our major hospitals. I needed comprehensive data on everything related to infant care. Birth rates, mortality statistics, common causes of death, hospital protocols, physician training, and any major medical advances or setbacks that had occurred in our city over the past century. The initial research was exactly what I expected. I found steady improvements in infant survival rates as medical knowledge advanced through the decades. The introduction of antibiotics in the 1940s dramatically reduced deaths from infections. A better understanding of nutrition decreases mortality from malnutrition and failure to thrive. Improved surgical techniques allowed doctors to save babies with birth defects that would have been fatal in earlier eras. I spent weeks creating charts and graphs, tracking the gradual but consistent improvement in neonatal outcomes from 1920 through the present day. The story was inspiring, a testament to the power of medical progress and the dedication of healthcare professionals who had worked tirelessly to save babies' lives. But then, as I was double-checking my data against records from the Centers for Disease Control and the Tennessee Department of Health, I encountered something that stopped me cold. According to every official record I could find, Memphis had one of the highest infant mortality rates in the entire United States during the 1930s and 1940s. Not just high, the highest in the nation for several consecutive years. For a city with multiple well-established hospitals, trained physicians, and relatively good infrastructure, this should have been impossible. Let me put this in perspective for you. As a neonatologist, I know exactly what causes high infant mortality rates. Poor prenatal care leads to more premature births and birth complications. Malnutrition in mothers results in low birth weight babies who are more vulnerable to illness. Lack of access to hospitals means that birth complications can't be properly managed. Infectious diseases like tuberculosis, influenza, or whooping cough can devastate infant populations. Environmental factors like contaminated water or air pollution can increase respiratory problems in newborns. These are typically problems you see in rural areas with limited medical resources, regions affected by extreme poverty, or areas impacted by war or natural disasters. But Memphis in the 1930s and 1940s had none of these excuses. The city had Methodist University Hospital, which had been providing quality medical care since 1918. Baptist Memorial Hospital was established in 1912 and had an excellent reputation throughout the region. St. Joseph Hospital has been serving the community since 1889. There were numerous private clinics and several trained obstetricians and pediatricians practicing in the city. Memphis was also a major river port and railroad hub, which meant it had better economic stability than many other southern cities during the Great Depression. The infrastructure was solid: clean water, electricity, decent housing in most areas. By all rights, Memphis should have had infant mortality rates comparable to other major southern cities like Atlanta, Birmingham, or Nashville, or even better. Instead, the data showed mortality rates that were absolutely off the charts. In 1935, Memphis recorded an infant mortality rate of 94 deaths per 1,000 live births. To put that in perspective, the national average that year was 55 deaths per 1,000 births. Cities like Boston and San Francisco had rates in the low 40s. Even rural agricultural areas typically didn't see rates above 70 per 1,000. But what made the Memphis data even more confusing was the pattern of these deaths. They weren't evenly distributed across all hospitals or all neighborhoods. They seemed to cluster around specific time periods and specific institutions. There would be months where reported infant deaths would spike dramatically, then suddenly return to more normal levels for a period, only to spike again without any apparent cause. I remember sitting in my office at 11 p.m. on a Tuesday night in December, staring at spreadsheets full of numbers that simply didn't make sense from any medical perspective. I had charts spread across my desk showing mortality patterns that defied every principle of epidemiology I had learned in medical school. Peak mortality years that corresponded to no known disease outbreaks. Sudden spikes in reported deaths that would last for 3 or 4 months, then inexplicably drop back to baseline levels. Mortality rates at certain hospitals were 3 or 4 times higher than at other facilities in the same city, sometimes in the same month. If Memphis had been experiencing a tuberculosis outbreak, I would expect to see corresponding increases in adult mortality and specific patterns of lung disease in autopsy reports. If there had been contaminated water or milk supplies, the effects would have been visible across all age groups and all parts of the city. If medical incompetence or equipment failures were to blame, I should have been able to find newspaper reports, medical board investigations, or lawsuits from the period. But I could find no evidence of any of these factors. The Memphis newspapers from the 1930s and 1940s contained no reports of unusual disease outbreaks, contaminated food or water supplies, or scandals involving local hospitals. In fact, the newspapers seemed to consistently praise the quality of medical care available in the city. Something was very, very wrong with this data, and as a scientist, I knew there had to be an explanation. That's when I decided to dig deeper into the specific causes of death listed in the historical records. What I found made my blood run cold. A significant percentage of the infant deaths in Memphis during this period were attributed to causes that, frankly, didn't make medical sense for the time period and circumstances. Failure to thrive in otherwise healthy newborns whose birth weights and early feeding records suggested they should have been thriving. Sudden infant death occurs in babies with no apparent risk factors and no family history of genetic disorders. Complications of prematurity in infants who, according to their birth records, had been born at full term with normal birth weights. Congenital heart defects in babies whose birth certificates indicated normal APGAR scores and no signs of distress immediately after delivery. But the most disturbing pattern I discovered was in the documentation itself. Many of the death certificates from this period were signed by the same small group of physicians. Dr. Vernon Halsey signed over 200 infant death certificates between 1935 and 1940. Dr. Martin Alden signed nearly 150. Dr. Lawrence Whitaker signed more than 180. To give you some context, in my 22 years as a neonatologist at one of the busiest children's hospitals in Tennessee, I have signed fewer than 50 death certificates total. Modern neonatal intensive care has dramatically improved survival rates, but even accounting for medical advances, the number of deaths these doctors were certifying seemed impossibly high. Moreover, many of these death certificates had minimal details about the actual cause of death. Instead of specific medical terminology describing disease processes or anatomical defects, they contained vague phrases like constitutional weakness, inability to sustain life, or complications following birth. These are not terms that competent physicians would use when describing the death of a patient. They're the kind of language you might expect to see from someone who was trying to document a death without actually examining the patient or understanding what had caused it. Even more troubling, many of these death certificates should have triggered investigations or follow-up care, but I could find no evidence that such investigations had ever taken place. Deaths attributed to sudden infant death should have resulted in autopsies to rule out infectious disease or other public health threats. Deaths from congenital heart defects should have been reported to medical researchers studying these conditions. But in a shocking number of cases, there were no corresponding autopsy reports, no burial records, and no follow-up investigations. It was as if hundreds of babies had simply vanished from the official record after being declared dead. At this point, I need to be clear about something. As a medical professional, I'm trained to look for patterns, to question anomalies, and to never accept data that doesn't align with known medical science. But I'm also trained to be careful about making accusations without solid evidence, especially accusations that would implicate colleagues in the medical profession. What I was seeing in these records was highly suspicious, but I needed to understand what had actually happened in Memphis during those years before I could draw any conclusions. I decided to expand my research beyond just medical records and start looking at the broader historical context of Memphis in the 1930s and 1940s. That's when I discovered something that led me down a rabbit hole I'm still trying to fully comprehend. It turns out that during this exact time period, Memphis was home to an organization called the Tennessee Children's Home Society, run by a woman named Georgia Tann. On the surface, this organization appeared to be a legitimate adoption agency that found homes for orphaned children. Georgia Tann was widely respected in the Memphis community. She had connections with prominent families, politicians, and even federal officials. She was frequently quoted in newspapers discussing child welfare issues. She gave speeches about adoption reform in Washington, New York, and other major cities. She was even consulted by Eleanor Roosevelt on matters related to children's welfare policy. The Tennessee Children's Home Society appeared to be doing important work. During the Great Depression, many families were struggling economically and couldn't care for their children. The organization claimed to find loving homes for these children with families who could provide better opportunities. Local newspapers regularly featured heartwarming stories about successful adoptions facilitated by Tann's organization. But as I researched deeper into the history of this organization, I began to discover disturbing details that had been largely forgotten or ignored by local historians. The first red flag was the sheer volume of children that the Tennessee Children's Home Society claimed to have placed. According to their own records, they facilitated over 5,000 adoptions between 1924 and 1950. That's an average of nearly 200 adoptions per year, which seemed extraordinarily high for a single agency serving primarily the Memphis area. Modern adoption agencies, even large ones with statewide reach, typically handle 50 to 100 adoptions per year. The infrastructure required to properly vet adoptive families, provide counseling services, and ensure appropriate placements for 200 children annually would have been massive, requiring dozens of social workers, psychologists, and administrative staff. But according to employment records I found in city archives, the Tennessee Children's Home Society employed fewer than a dozen people at any given time. Georgia Tann herself appeared to personally handle most of the major decisions about child placements, which should have been impossible given the volume of cases they claimed to be managing. The second red flag was the geographic distribution of these adoptions. While the organization was based in Memphis and drew children primarily from Tennessee, Arkansas, and Mississippi, the vast majority of adoptive families were located in New York and California. This seemed highly unusual since adoption agencies typically focus on finding local families for children to minimize disruption and maintain community connections. But Tann's organization was shipping children across the country to adoptive families they had never met, in states with completely different laws and regulations regarding adoption procedures. This should have raised immediate concerns among social workers and legal authorities, but I could find no evidence that anyone had questioned these practices. The third red flag was the secrecy surrounding the organization's operations. Most legitimate adoption agencies maintain detailed records about the children in their care, the birth families, and the adoptive families to ensure proper medical care and to facilitate contact if medical emergencies arise. But the Tennessee Children's Home Society was notorious for destroying records and providing minimal information to adoptive families about children's backgrounds. They claimed this secrecy was necessary to protect the privacy of birth mothers, but it also made it impossible for anyone to verify whether their practices were legitimate or whether children were being placed in appropriate homes. As I continued researching, I began to find scattered references in old newspaper clippings and legal documents that suggested the Tennessee Children's Home Society was not the benevolent organization it appeared to be. A 1941 report by the Child Welfare League of America noted concerns about the organization's practices and recommended that it be investigated by state authorities. A 1946 letter from a Memphis probate judge expressed alarm about the number of children being removed from families without proper legal justification. A 1949 newspaper editorial questioned why so many children from Tennessee were being adopted by families in other states. But these concerns seem to have been ignored or suppressed by local authorities. Georgia Tann had powerful political connections, including a close relationship with Edward Boss Crump, who controlled Memphis politics for several decades. Anyone who tried to investigate or criticize the organization found themselves facing political pressure or legal threats. It wasn't until I found a copy of a 1950 investigative report by Tennessee Attorney General Robert Taylor that I began to understand the full scope of what had been happening in Memphis during those years. According to Taylor's investigation, the Tennessee Children's Home Society was not an adoption agency at all. It was a criminal enterprise that systematically stole babies and young children, primarily from poor families, and sold them to wealthy adoptive parents across the country for enormous profits. Georgia Tann didn't just find homes for orphaned children. She actively worked to create orphans by taking children away from families who could have cared for them and by stealing babies from hospitals immediately after birth. And here's where my discovery as a neonatologist becomes truly horrifying. Georgia Tann's preferred method of acquiring babies was to work with hospital staff to steal newborns directly from maternity wards, and then to have physicians issue false death certificates to cover up the thefts. The scheme worked like this. Tann had developed relationships with nurses and doctors at several Memphis hospitals. When unmarried women or poor families gave birth, hospital staff would take the babies immediately after delivery, claiming they needed special medical care or had to be transferred to another facility for treatment. The mothers, who were often heavily sedated during delivery, as was common practice at the time, would be told hours or days later that their babies had died from complications during birth or shortly afterward. False death certificates would be issued, signed by doctors who were part of the conspiracy, listing vague medical causes that couldn't be easily verified. The babies, meanwhile, would be taken to Tann's facility, where they would be held until they could be placed with adoptive families who were willing to pay substantial fees, sometimes equivalent to $50,000 or $70,000 in today's money. This explains everything I had been seeing in the mortality data. The unusually high infant death rates weren't due to medical failures, disease outbreaks, or environmental factors. They were the result of systematic document fraud on a massive scale. Hundreds of healthy babies were being declared dead when they were actually being trafficked across state lines for profit. The clustering of deaths around specific hospitals made sense now. Those were the facilities where Tann had corrupted medical staff. The spikes in mortality during certain time periods corresponded to periods when Tann was actively seeking babies to fulfill orders from adoptive families. The vague causes of death on certificates reflected the fact that the certifying physicians had never actually examined deceased infants because those infants were still alive. But the story gets even worse. According to the Taylor investigation and testimony from survivors who came forward decades later, the children who weren't quickly placed in adoptive homes were kept in deplorable conditions at Tann's facility on Poplar Avenue in Memphis. The building was overcrowded, with dozens of children crammed into rooms designed for much smaller numbers. Basic sanitation was neglected, with limited bathroom facilities and inadequate cleaning. Medical care was minimal, with children receiving little or no treatment for illnesses or injuries. Many children were kept sedated with medications to keep them quiet and manageable. Those who became sick were often left untreated. Children who cried or caused problems were physically abused by staff members. As a result of these conditions, many children actually did die in Tann's care. The Taylor investigation estimated that as many as 500 children died from neglect, malnutrition, disease, and abuse while being held at the Tennessee Children's Home Society. This means that some of those death certificates I had been analyzing represented real tragedies caused by criminal negligence, not just fraudulent documents. Over the past 2 months since making this discovery, I've been researching the documented cases of Georgia Tann's victims who have come forward over the decades. These real stories have been among the most heartbreaking aspects of my investigation into this medical tragedy. The most famous case is that of Alma Sippel and her daughter Irma. In 1946, when Irma was just a toddler, she came down with a cough. Georgia Tann approached Alma, claiming she could get the child free medical care at a better hospital. Alma, being a poor single mother, was grateful for the help. But when Alma arrived to pick up her daughter, she was told by hospital staff that Irma had died during treatment. A death certificate was issued, and Alma was told her daughter had been buried immediately. What Alma didn't know was that Irma was very much alive and had been placed with an adoptive family through Tann's organization. For 43 years, Alma grieved the loss of her daughter, never knowing that Irma had grown up believing she was an orphan whose mother had abandoned her. It wasn't until 1989, when the television show Unsolved Mysteries featured Georgia Tann's crimes, that Alma learned the truth. She contacted the show, and incredibly, they were able to locate Irma, who was then a grown woman with children of her own. Their reunion was emotional beyond description. Irma had spent her entire life wondering about her birth mother, never knowing that Alma had been told she was dead. The medical records that I've been able to review show that Irma was never seriously ill. The death certificate claiming she died from pneumonia was completely fraudulent. Another devastating case that has come to light is that of Devereaux Devi Eiler. Devi grew up knowing she was adopted, but it wasn't until she was in her 70s that she discovered the horrifying truth about her origins. Her adoptive parents had been told she was an orphan whose parents had died, but genealogical research revealed that her birth mother had been alive for decades after the supposed death. Through DNA testing and extensive research, Devi discovered that she had been stolen as an infant and that her birth mother had been told she died shortly after birth. Even more incredibly, she learned that she had a biological sister, Patricia Ann Wilkes, who lived just a few hours away in Tennessee. In 2009, at the age of nearly 80, Devi met her sister Patricia for the first time. Patricia had also spent her entire life believing that her baby sister had died in infancy. Their mother had gone to her grave, never knowing that both of her daughters were alive and had been raised by different families. Devi later wrote a book about her experience called "No Mama, I Didn't Die. My Life as a Stolen Baby." In it, she describes the profound psychological impact of learning that your entire life history is based on lies and the complex emotions involved in discovering biological family members so late in life. Perhaps the most disturbing case I've encountered is that of Cindy Lou Presto, whose real name was Sandra Lee Bridgewater. In 1947, when Sandra was just 2 years old, she was playing in a park near her home when Georgia Tann's operatives literally kidnapped her in broad daylight. Sandra's mother, Evelyn Bridgewater, immediately reported her daughter missing and spent months searching for her. But when Evelyn tried to pursue legal action, she discovered that Sandra had been taken to Judge Camille Kelly's courtroom, where legal papers had been forged claiming that Evelyn was an unfit mother who had abandoned her child. Despite Evelyn's protests and her attempts to prove that Sandra had been kidnapped, Judge Kelly ruled that the child should be placed for adoption through the Tennessee Children's Home Society. Sandra was given a new identity and placed with a wealthy family who had no idea they were participating in a kidnapping. For 32 years, Evelyn never stopped looking for her daughter. She hired private investigators, contacted every adoption agency she could find, and never gave up hope that Sandra was still alive. Meanwhile, Sandra grew up believing that her birth mother had been an unfit teenager who had given her up willingly. It wasn't until Sandra's adoptive mother died and she found correspondence from Georgia Tann among her mother's belongings that she began to question her origin story. When she started researching her background, she discovered the truth about the Tennessee Children's Home Society and realized that she might have been kidnapped rather than abandoned. Through a combination of private investigators and sheer determination, Sandra and Evelyn were finally reunited in the late 1970s. Evelyn was able to tell her daughter about the years of searching, the private investigators, the false leads, and the devastating grief of losing a child to what she knew was a criminal enterprise but couldn't prove. These documented cases represent just a tiny fraction of the thousands of families that were destroyed by Georgia Tann's operation. What makes them particularly relevant to my research is how they demonstrate the sophisticated medical fraud that was required to make these kidnappings appear legitimate. In each case, false medical documentation was crucial to the scheme. Death certificates were issued for living children. Medical records were falsified to support claims that birth mothers were unfit or had died. Hospital staff participated in the deception by providing false information to mothers about their children's condition and whereabouts. These stories represent just a fraction of the families torn apart by Georgia Tann's operation. Fewer than 10% of Tann's victims were ever reunited with their biological families due to record destruction and official complicity. What's particularly chilling to me as a medical professional is how many doctors and nurses must have been involved. Every false death certificate required a physician's signature. Every stolen baby required hospital staff cooperation. The corruption was systemic throughout Memphis's medical community. This makes me think about the oath every physician takes. First, do no harm. The doctors who participated didn't just fail this standard. They actively participated in causing immeasurable harm to thousands of families. Georgia Tann operated this scheme for 26 years, from 1924 to 1950, trafficking over 5,000 children and making profits equivalent to over $10 million today. The operation only came to light when Governor Gordon Browning ordered an investigation in 1950, but justice was limited. Georgia Tann died of cancer just days before the scandal became public, so she was never prosecuted. Most other officials escaped accountability as well. As a neonatologist, this case has fundamentally changed how I think about my profession. Every day I work with families during their most vulnerable moments. They place enormous trust in medical teams caring for their children. The doctors and nurses who participated in Tann's scheme violated that trust in the most profound way possible. I've made it my mission to ensure awareness of these crimes doesn't fade. I've reached out to medical schools to incorporate this into ethics curricula. I've been working with genealogy organizations to help identify potential victims. If you believe you might be connected to Tann's operation, I encourage DNA testing and family research. New genetic databases are making connections possible that were impossible years ago. The children Tann stole are now in their 70s and 80s. Time is running out, but it's not too late. Every DNA match brings us closer to giving families the truth they deserve. Georgia Tann may have thought she could erase these children's identities forever, but she couldn't erase their DNA or destroy the human desire to know where we come from. The truth is still out there, waiting to be discovered.